My name is Christian Squillante. I am a medical oncologist at the MD Anderson Cancer Center at Cooper. My primary responsibilities in my position are the management of solid tumor patients from a clinical standpoint, particularly thoracic oncology, head and neck oncology, and genitourinary oncology. But in addition to this, I serve as the co-director for the GU program at MD Anderson at Cooper, and I also serve as the director for solid oncology tumor research. So in that role, my primary responsibility is to help develop, recruit, and open clinical trials for our cancer patients at our cancer center in the field of solid tumor oncology.
What are antibody drug conjugates and how do they differ from some of the traditional cancer therapies that have been around for many years?
Right, so it's kind of a new and developing field in the area of oncology. So if you think about classic cancer treatments and therapeutics, people tend to think about chemotherapy as like the stalwart of treatment for cancer. And chemotherapy, the way I describe it is it's like, spraying weed killer on your entire garden, right? So you're going to get the bad stuff, but you're also going to get some of the good stuff as well. So chemotherapy is a systemic therapy. It goes generally into your veins and then gets to every cell in your body. So the good part of that is it can kill cancer cells. The bad part of that is it can kill good, healthy cells as well. And that's where we get all our side effects of chemotherapy from. But antibody drug conjugates are really a newer type of cancer treatment that really kind of combines what we call an antibody or a monoclonal antibody with a chemotherapy agent or the cytotoxic drug. And so I kind of consider these to be like the Trojan horse. If you think about them, the idea is that the antibody can get onto a cancer cell and then get inside of the cancer cell. And then once it's inside the cancer cell, that linker kind of breaks apart, and then that chemotherapy or that cytotoxic drug is now floating inside of the cancer cell and is able to do its damage and kill the cancer cell itself. So basically the Trojan horse sneaks in, opens up, releases the soldiers, and the soldiers run around and are able to kill the cancer cells. So really, ADCs are like the Trojan horse of new cancer cell treatment. So, this is a kind of a cool thing in that the idea is it can be much more specific to the cancer cells. You're not spraying the whole garden. You're just getting to the cancer cells themselves. And the hope is that, you have a better targeted therapy that works a little bit more effectively with diminished side effects.
What are some of the strategies that you implement to mitigate some of these side effects?
Yeah, so again, this is an extremely complex area of discussion right now. So I'll try to, get some key points there in on this. So when you're talking about strategies for mitigating the toxicity of, these antibody drug complexes or bispecific antibodies, one thing, for instance, I think of, especially with the bispecific antibodies where you can get these horrible reactions, the cytokine release syndrome, is what we call step-up dosing. So it's not necessarily coming in and just hitting the patient with the full dose on the first try. That would put you kind of most at risk for getting a nasty reaction. It's more so, starting with a little dose, seeing how they're doing, getting that immune system to adapt and recognize the agent to minimize the risk of immune toxicity, and then increasing the dose, often doing this in a hospitalized or closely watched setting. Those are some of the strategies that are currently in place and being explored to kind of minimize that risk to patients from having a horrible side effect. Other strategies can include, carefully analyzing and managing, the pre-medications for a patient that are administered to minimize reaction. And then, on the more cellular level, which is a bit outside kind of the scope of a clinical practitioner such as mine, but, we still understand this. It's really developing and engineering the drugs for, a more specific affinity for the antigens to minimize toxicity. Really getting those targets precise, really knowing what targets you're using to minimize that cross-reactivity. Those are some of the basic but main strategies I would think of that are being used to kind of help minimize the toxicity of these drugs or off-label toxicities. Well, it isn't exciting.
What are some of the strategies that you implement to mitigate some of these side effects?
Yeah, so again, this is an extremely complex area of discussion right now. So I'll try to, get some key points there in on this. So When you're talking about strategies for mitigating the toxicity of, these antibody drug complexes or bispecific antibodies, one thing, for instance, I think of, especially with the bispecific antibodies, where you can get these horrible reactions, this cytokine release syndrome, is what we call step-up dosing. Right. So I think some of the big advantages are that we have proven in a number of cancers that bispecific drug conjugates and antibody drug conjugates can be very effective in the treatment of cancer. And they've really, broadened our weapon arsenal against fighting cancer. Classic chemotherapy, especially for patients with stage 4 disease, it works for a little bit and then it stops working. And then patients can have limited treatment options. So we need more weapons to fight the cancer. So we have a number of these drugs that exist. And they're really broadening our ability to, overcome those generic chemotherapy mechanisms that become resistance mechanisms and give patients an additional option to fight their cancer. So I'd say first and foremost, you have 2 new classes of medicines basically that are giving patients an opportunity to live longer and hopefully live better with their cancer. And that's the second big advantage, is that, again, for the most part, these drugs do have their own sets of side effects and, toxicities, but we can see significantly diminished side effects compared to classical chemotherapy with these treatments. And so I think those are 2 things that are a huge benefit to patients. You're talking increasing not just the quantity of their life, but the quality of their life. But like you said, that doesn't come without some challenges that come with these drugs. One of the things is they're generally very expensive. These drugs are expensive to develop, expensive to study, and expensive to manufacture. So, in the world of insurance in the United States, these can become prohibitively expensive in some cases. And so how do we manage the cost of healthcare and the development of these drugs? That's a challenge. Other things is that they're not perfect. You can still have, off-target side effects. You can still have toxicities. So how do we even better refine the targets of these drugs to minimize side effects? And then last but not least, we kind of touched on this a little bit earlier, is that, if I have a tumor, not every cancer cell in that tumor is going to be exactly the same. Some of those cancer cells may have the target. Some of those cancer cells may not have the target. So the complications of what we call heterogeneity in the targets of cancer cells can make these drugs somewhat difficult to manage. And those are the things that we have to really work to overcome.
What are some of the common operational or logistical challenges that you would have in operationalizing a study with a drug conjugate as compared to maybe some other oncology drugs or oncology studies?
In the old days, clinical trials, although we had much less of them, they were a little bit simpler. It was, do you have the disease? Okay, we have a drug that we're going to explore in the disease. And so it was a pretty simple design. But as we mentioned, in a lot of these drugs, you have to make sure that the biomarker exists. So the first thing is, you have to be able to test for the biomarker, identify the biomarker in a reasonable period of time. Sometimes these can take weeks to identify, and then make sure patients are positive for that biomarker. And so part of it's defining the threshold, like what % of the cancer cells need to have that biomarker, what % of patients need to have that biomarker for you to consider them inclusions in the trial. That's part of the things that go into the trial design. And then, pharmacokinetic monitoring when these drugs are in early phase development to kind of track like how available are these drugs to the cancer tissues. That can be a little bit more challenging.
Mm-hmm.
That sometimes requires more specialized testing and monitoring that, not every center is going to have. And then lastly, especially with the bispecific antibodies as opposed to the single antibody drug conjugates, you can get some serious immune-mediated side effects, things like cytokine release syndrome. That can be even deadly in some patients. So some of these trials, or even when we're administering these drugs as part of our standard of care, can really require very close monitoring of patients or even hospitalization. And that adds a whole nother layer to the care of the patient and how you're managing these drugs and how you're managing these trials. And that can make the trial design more complicated. I would say, though, on a personal note, and I say this to my patients, more complicated doesn't always mean we shouldn't do it. It just means it's something you need to be aware of as part of the quote unquote cost of developing these drugs and administering them to patients. I mean, there's a great value to these drugs. in cancer care right now, even though it may be a little bit more difficult.
Thinking about the logistical challenges with PK testing, or perhaps with the potential side effects that you were talking about, and some additional training that could be provided to your teams. What sort of support would be useful to you and to your site when conducting these types of trials?
Yeah, so when we're opening trials that involve ADCs or bispecific antibodies, you want to make sure first and foremost that the trial design is something like your typical cancer center can support. Am I able to get all your pharmacokinetic studies done within like the infusional hours window? Like we don't want our staff there 24 hours trying to deal with some of these things, because that can definitely lead to burnout. So making sure the trial design isn't so cumbersome for not just the staff, but for the patient to be undergoing it, I think is important. And then if there's any specialized testing or equipment that's needed, you want to make sure that that's provided, that the appropriate trainings are provided so that everyone's on the same page and that the trial can be run effectively. Some of these things, like I said, are quite nuanced, and people don't have as much experience with them as compared to more classical agents. So you want to make sure the training's there, that the support's there, and if necessary, that the financial support's there for the resources to be in place for, the research nursing, the research support staff, the research techs to be, engaged in the trial and be able to execute it effectively. Well, it is an exciting time. I was just thinking about this earlier today that, in the 2010s, we had this massive expansion of immunotherapy being developed for cancers, particularly solid tumors. We had the development of CAR T cells for our leukemias and lymphomas. There was this huge boom in terms of identifying, these immune therapy agents, and we continue to have this exploration, just like you said, into multiple other classes of drugs. So I think this is a piece of the pie, right? These are two classes of medications that work differently than immune therapy, work differently than chemotherapy, work differently than targeted therapy, work differently than radiotherapy, work differently than hormonal therapy. So when you're looking at the landscape and you have a lot of these different pieces of the puzzle of cancer care, I think, currently we're generally using these therapies alone as single agents in general. But I think one of the big areas of exploration would be, how do we start using these drugs with some of the existing agents that we have in combination or in sequence or as a form of switch maintenance? How will we use these drugs with our current arsenal to maybe work synergistically? Sometimes 1 + 1 doesn't equal 2. Sometimes 1 + 1 = 3. So if we can add these to some of our existing drugs, can we get more of an effect? I think that's going to be an area where we see these drugs heavily developed. And I think we'll also see them being developed in different settings. So, a lot of these drugs are used in refractory or stage 4 metastatic patients right now. Will we start exploring these drugs in the curative setting to see, can these not only work on cancer cells to, increase, cell death, but can we increase cure of cancer with these drugs? I'd really like to see some answers come out with some of our existing ADCs and bispecific antibodies of, can we move these into the more curative setting in different tumor cell types to see if we can get an increase in cure, because that's always our ultimate goal. We really want to increase cure. So I suspect we will continue to explore these drugs in those contexts. And I think finally, and we've alluded to this already, exploring more specific biomarkers and more specific targets for these drugs to make them even more effective and less toxic.